I'm Dr. Linda Cheyenne Vakari, Infectious Diseases and Microbiology Registrar in London, UK. Here, I am presenting our approach to ending the HIV epidemic at Croydon University Hospital through our program entitled Sustained 97% Opt-out HIV Testing in the Emergency Department, Getting to Zero AIDS through Earlier Diagnosis and Reduced Onward Transmission. 1 in 14 people living with HIV in the UK are still undiagnosed. 2020 UK BIVA guidelines recommend opt-out HIV testing in emergency departments, EDs, in all areas of more than 2 per thousand HIV prevalence. As a result, several London hospitals had implemented HIV testing prior to 2020, demonstrating its feasibility, but these programs were limited by rate of testing. Our area has a very high prevalence of more than 5 per thousand, with a 46% late diagnosis rate and a predominantly heterosexual Black African HIV cohort. We implemented an opt-out HIV testing program in RED at Croydon University Hospital in May 2020, with the aim of achieving and sustaining high testing rates. Our program works as follows. Posters and leaflets clearly explaining opt-out HIV testing are prominently displayed in ED, signposting patients to clinical staff if they wish to opt out. All patients aged 16 and above undergoing venipuncture have a HIV test unless they opt out. All non-negative results are managed by the HIV team. Defaulters are contacted and offered linkage to care. Those with new reactive tests are promptly invited to attend for point-of-care test and repeat serology, with linkage to HIV care that day where appropriate. The final outcome is recorded to the hospital system. The key processes we put in place to achieve high testing rates included a fourth-generation HIV test request, which is automatically added to any venipuncture order and taken in a separate biochemistry sample to reduce the risk of contamination. Samples are tested on a single Roche assay to allow rapid turnaround and cost saving. The IT system automatically blocks duplicate testing of repeat attenders or testing of patients who have opted out within the past 6 months. The HIV team receives an automated daily report of all non-negative HIV results to action as previously, thereby lifting the responsibility for the test results from busy emergency department staff. Stakeholder engagement and a robust results management system were the cornerstones of our program. This has allowed us to test over 40,000 people per year and achieve and sustain more than 97% testing rates for 2.5 years now. The problem of late diagnosis is multifactorial. In many cases, diagnosis is delayed due to the very heterogeneous clinical presentations of HIV, which can mimic many other disorders, and the natural history of the disease itself, with a prolonged, usually asymptomatic period between seroconversion and the profound immunosuppression of advanced disease, further confounds things. As a result, prior to being diagnosed with HIV, patients often undergo unnecessary investigations and experience a lot of misdiagnosis, leading to significant delays in administering correct, life-saving treatment. Late diagnosis often requires complex investigations for opportunistic infections and management of AIDS-defining illnesses with high morbidity and mortality, as well as risks of IRIS on starting antiretroviral treatment. Ongoing stigma and lack of knowledge around epidemiology, transmission, and presentations of HIV in both the general public and healthcare workers has equally hampered efforts to control the HIV epidemic. The only clinical areas in which HIV testing is happening effectively in the UK are sexual health and antenatal clinics, where it has become routine. Outside of these settings, it has been very difficult to overcome the now clearly historical concerns about obtaining consent for HIV testing, leading to erroneous preconceptions of who we should test and when, and undue concern over asking patients for permission to test. This has repeatedly caused opt-in methods of HIV testing to fail. Crucially, HIV testing is acceptable to patients. A local testing acceptability survey we conducted in our AMU in 2011 demonstrated that over 90% of inpatients would be happy to have a HIV test, although only 0.9% had been offered one. In our hospital, we are now diagnosing more cases of HIV in emergency department than in the sexual health clinic, antenatal clinic, and all other outpatient clinics combined. Our tested HIV prevalence in ED is above 7 per thousand, significantly higher than the local recorded prevalence of 5.84 per thousand, demonstrating the importance of testing in this setting. Many of our newly diagnosed patients have had missed diagnostic opportunities, previously having presented to our hospital with chronic hepatitis B, ophthalmic zoster, and high-grade cervical intraepithelial neoplasia, amongst others. The normalization of HIV testing in our hospital is contributing to increasing clinician confidence and awareness of the natural history and disease presentation of HIV by destigmatizing the inclusion of HIV in the differential diagnosis. This is changing the culture away from stigma-limited targeted testing. Comparing newly diagnosed patients in the 2 years since implementation to our HIV cohort pre-testing in 2017 to 2018 shows staggering results. We have diagnosed almost 3 times as many patients as we were prior to implementation. Admissions to ITU have dropped from 15% to 0. Mortality has reduced from 23% to 0. The average length of stay of newly diagnosed patients has reduced from 35 days to less than 10 days. Repeat ED attendances and readmissions have also reduced from 31% to 11%. Although our late diagnosis rate has increased by 50%, the proportion of AIDS-defining illnesses in newly diagnosed patients has dropped from 46% to 27%, and consequently, morbidity and disability, as well as treatment costs, have decreased. This demonstrates that we are finding patients with advanced disease earlier, before AIDS-defining illnesses have developed. For example, in the first year of the program, we diagnosed a patient who had presented to the emergency department with high blood pressure following an argument with his relative and was discharged with antihypertensives. We were able to link him to care and identify that he had been experiencing subtle behavioral changes, prompting us to arrange MRI brain imaging. This revealed cerebral toxoplasmosis. In view of the early diagnosis, we were able to treat this patient as an outpatient, avoiding admission to hospital and preempting the onset of seizures or disability. The program has significant impact beyond the new diagnoses. As newly diagnosed patients now have much shorter, less complex admissions, the bulk of the HIV inpatient workload is moving more and more towards the complex management of patients who have defaulted care. We have been able to identify patients who had previously defaulted care as having HIV early in their hospital admissions, thereby recommending appropriate investigations and prompt treatment, as well as offering re-engagement to HIV care. We were initially able to re-engage 45.2% of these patients identified through opt-out testing, and at least 25.8% are definitely still in care today. Retaining defaulters in care is now the new challenge. For our patients engaged in care, this program can alert us to other issues that they are facing, allowing us to intervene if needed. For example, prompting us to review their antiretrovirals if their cardiovascular status, hepatic and renal function, or bone health has changed, or if they have been started on potentially interacting medications. For patients with psychiatric illness or drug and alcohol abuse, this program can help us offer linkage to dedicated HIV mental health services and prevent crises that can in turn impact on their adherence to HIV treatment. One of the most crucial aspects of the project with regards to ending the HIV epidemic is the impact on onward transmission. Through effective partner notification, we have offered testing to all contactable sexual partners of our newly diagnosed patients, as well as counseling recent or regular partners about post or pre-exposure prophylaxis, condoms, and treatment as prevention. In 2017, we presented a local project scrutinizing partner notification of our cohort at the BIVA annual conference. We found that 92 or 35% of 261 contactable partners of 250 index patients were verified as HIV positive. In contrast, of the 37 patients newly diagnosed through our program in the first 2 years, 2 or 5.4% had partners already known to have HIV infection, and only 1 patient, or 2.7%, has a partner who has tested positive since their diagnosis, with 23 current partners verified as HIV negative. This significant difference is well illustrated by a case in which a young patient was admitted with headache and photophobia and about to be discharged by the medical team in view of a normal lumbar puncture result. His ED HIV screening test was reactive. He was actually seroconverting and had a viral load of 16 million. His regular male partner's HIV test 45 days post unprotected anal intercourse is negative. With significantly improved health outcomes and interruption of onward transmission, the program has significantly reduced litigation and medical legal risks. Some of the clinical scenarios we were encountering prior to implementation are now thankfully unfathomable, like the case of the double transmission in February 2020. A man transmitted HIV to his wife in the second trimester of pregnancy, who then transmitted the virus to the baby. The infant was only diagnosed following admission to ITU, where he required treatment for TB and PJP, and where he developed iris on starting antiretroviral treatment. The parents were diagnosed as a result of the child's diagnosis, although collectively the 3 family members had 16 hospital contacts between them in the previous year, all missed opportunities for testing. In contrast, in the first year of our testing program, we diagnosed a young woman with HIV after she attended ED with pyelonephritis. She was 4 months pregnant, and initiation of treatment prevented transmission to the child. All these outcomes are also associated with staggering cost savings. Conservative estimates of around £350,000 to £500,000 per year of savings to the hospital and £4 to £8 million to the wider NHS in prevented onward transmissions and their associated lifetime healthcare costs. In the context of fast-track cities, our target of ending new HIV infections by 2030, our work demonstrates that shifting the emphasis on early diagnosis through opt-out testing in EDs is a key strategy to reducing onward transmission of HIV by reducing exposure time and diagnosing patients before they develop AIDS-defining illnesses, with the associated rise in viremia and higher risk of transmissibility. Our program has been recognized internationally for its success, but also for its simplicity and sustainability, and therefore its reproducibility in other settings. The program has had a huge impact on all aspects of Croydon's local plan towards zero, allowing us going forward to focus on retaining and re-engaging patients in care, prevention, effective partner notification, and testing all children of newly diagnosed patients. On World AIDS Day 2021, the UK government pledged £20 million to roll out opt-out HIV testing to all emergency departments in extremely high prevalence HIV areas. National opt-out HIV testing has successfully launched on the 1st of April 2022 in the whole of London, Manchester, Salford, Blackpool, Brighton, and Sussex. Using the opt-out model, all 3 bloodborne viruses, HIV, hepatitis B, and hepatitis C, will be tested, helping to achieve elimination by 2030. As you know, London was awarded a Circle of Excellence Award for its work at the recent Fast Track Cities event in Seville. Looking forward, we envision expanding testing to primary care and to emergency departments in other high prevalence areas across the globe, provided there is safe access to effective treatment for newly diagnosed patients. But supporting those already diagnosed to remain in care is equally important. I would like to thank Dr. Ian Cormack, HIV lead at Croydon University Hospital, who has been driving his vision for Croydon as a safe place for people living with HIV, and the whole multidisciplinary team at Croydon University Hospital, which has made this programme's success possible. From the emergency department to biochemistry, from information technology to management, and of course, to the whole HIV team. Thank you for the opportunity of presenting today.